All right. Good evening. One of the most important topics that always kind of throws the internist back is dermatology, and understanding that a dermatologic disorder is a manifestation of what is happening inside our body means that we have to have a good understanding. And so I'm going to try to illustrate how this relates to that in terms of systemic illness and the manifestation on the skin, and also discuss very quickly the important things. So these are the objectives of this live podcast. First thing, I'm going to start with something called the Jellincombe's classification of hypersensitivity. All of us know that hypersensitivity reactions are classified into four. Hypersensitivity reactions are the immune system's way of responding to antigens, and hypersensitivity means that the sensitivity of the immune system is more than it should be, meaning that it is doing damage extra to the function that it is supposed to give. Type 1 hypersensitivity reaction is an anaphylactic reaction. That means any form of allergy that you could possibly think of. And that includes eczema, it includes asthma, it includes anaphylactic shock as a whole. The way that happens is usually through an IgE mediated system. And then you have type 2 hypersensitivity reaction, where you have cell mediated immunity, meaning that you actually produce IgG or IgM. And then that will go ahead and attack a cell, an antigen on a cell or an antigen alone. And then your immune system cell will recognize its opsonized antigen and then kill it or take care of it. Then hypersensitivity type 3, and do excuse the oversimplification here. We've got a lot of material to go through. Type 3 hypersensitivity is the immune complex hypersensitivity reaction. In immune complex hypersensitivity, we have free antigens floating around, and we have antibodies that are in our immune system. Those combine together, an IgG and an antigen, and then that kind of hooks up to other antigen IgG or antigen antibody systems. Usually, type 3 are IgA or IgG hypersensitivity reaction mediations. What are the examples of those? Well, you have serum sickness, you have systemic lupus, and if you forget everything, then these two are enough for you to be able to provide lucid examples. Although, when you go ahead and search online what is serum sickness, you will find that Google Dictionary will give you that it is an allergic reaction. Actually, it's a hypersensitivity reaction. And what it does is it gives you skin rashes and stiffness and fever. And so, what are the other important type 3 immune complexes that we want to know? Extrinsic allergic alveolitis, especially the acute phase, and of course, post-streptococcal glomerulonephritis. The antigen antibody immune complex then can deposit in tissue and cause progressive damage that we really don't want to have. Then we have type 4 hypersensitivity reaction, or what is also known as delayed hypersensitivity. Those are usually T cell mediated. Now, the T cell likes to do things its own way. It's got its own intricate systems, quite smart actually. And so what happens is, for example, look at an example to try to elucidate the picture here. A tuberculin skin test is a delayed hypersensitivity reaction. A graft versus host disease is a hypersensitivity reaction. Notice that a graft versus host disease, when the transfused stem cell or the given graft engrafts itself inside your body and then attacks your own original body components. Allergic contact dermatitis, and that's important for the discussion here. And then things like scabies and extrinsic allergic alveolar reaction, alveolitis in the chronic phase. Multiple sclerosis is actually a delayed hypersensitivity in Guillain-Barré. So you can automatically know that a lot of our autoimmune activities are actually related to delayed hypersensitivity and immune complexes. All right, now that we understand that, let's go ahead and talk about the skin stuff. We're going to start with a type 1 related disease, eczema. And eczema is basically, well, it's a dry, red, itchy skin, right? And what happens is it's an inflammation that causes that, and you'll always have vesicles, and you will have what is called lichenification. The reason I decided to do this as a talk is because people get confused with the bullet points and the bizarre words. And so if we try to break those down into the simpler components, we'll be able to simply understand and kind of make it easier to us. So what is lichenification? That will be the first question that we want to ask. And then why do we get an inflammation? There are several types of eczema. The common types include atopic, contact, and dihydrotic, and then steatotic. And when you understand that there are different types, and you know that eczema, the one that is atopic, will be type 1 hypersensitivity. And then the thing that is contact dermatitis, what did we say? Contact dermatitis, we said that that would be type 3. Just checking that out. Our contact dermatitis is delayed hypersensitivity. And then we have steatotic and dihydrotic, where dryness or improper secretions on the skin will cause the inflammation, and then the redness, itching, and symptomatology. Atopic dermatitis is the development of eczema in patients with an inherited atopic diathesis. So if that is the case, we're going to look for family history. We're going to look for comorbid diseases such as asthma. Right away, you can see how that is related to internal medicine. And then you want to also look for waxing and weaning course, depending on what is the inciting factor that causes the eczema. Sometimes, most of the time, we don't know what that is. We want to look for pruritus along with the erythema. You want to look for erythematous papules and plaques that may be vesicular and maybe weeping. Weeping means that it is discharging something. That is a common term in dermatology. Right, so going back, I asked you a question a while back. What is lichenification? So lichenification is a skin condition that occurs in response to excessive itching and rubbing and itching and rubbing. And so what that does is it thickens your skin. We're going to come across shortly to so many different conditions where you use the word lichen. For example, lichen planus and lichen sclerosus. And those are things that you will come across in dermatology. As you become more accustomed to the terminology used, things kind of become easier for you. Fantastic. All right, so we're going to also have chronic lesions that may be lichenified or hyperkeratotic. And so the text here is basically telling me the same thing in two different manners. And then you can have involvement of the periocular areas of the flexure surfaces, including the posterior neck and the antecubital and popliteal fosses and wrists and ankles. And those are all areas of joints, and they're already areas where you can have hyperkeratotic skin because of the excessive movement increasing. And so it is, let's say, in a sense, it's more predisposed. So what are other causes? We have said that eczema is actually comprised of different types, right? And the different types we said are atopic, contact, dyshydrotic, and steatotic. So they are 4. And so you'd expect that you will have other causes for eczema. So for example, a staphylococcus infection will complicate eczema. And if someone is predisposed or having a hypersensitivity reaction, they can have a new skin eruption. And if they already have atopic dermatitis, then it'll be complicated by infections. Furthermore, they themselves are a predisposition to infections of the normal flora or even bacteria that are infectious. So not normal flora. Staph is normal flora, and then you should ask yourself, why are they a predisposition? It's because you are breaking down the barriers of the skin as you are itching, and then you will be able to diagnose that quickly as the internist or the hospitalist by looking for pustules, crusting, erosions, and then checking for systemic signs. So there are 2 types of contact dermatitis, okay? This is the allergic contact dermatitis and irritant contact dermatitis. And it is very fair to discuss contact dermatitis in the general topic of eczemas. And at this moment, and the way we just kind of dived in, you'd ask yourself a question: what is the definition of an eczema, right? So an eczema is a condition that makes you basically have inflamed skin that is red, dry, and itchy. And if it is not atopic dermatitis, then you cannot safely call it eczema the way that most people refer to eczema, which is this itchy sensation that comes because of hypersensitivity to an inciting factor or because of family predisposition, and it is related to other allergies. They'd have food, nut allergy, and egg allergy, and banana allergy, and they'd have asthma, for example, and they've had a couple of anaphylactic shocks, and and they have this skin eruption that's there for a long time, and it's waxing and waning. And I think the idea is now pretty clear. But you should understand that we have now discussed and been through atopic dermatitis, and we're going to go on to the next kind of eczema. Eczema, being inflamed, red, itchy skin, means that it is purely a descriptive term and not a condition. The condition will be atopic dermatitis 1. The next will be contact dermatitis. So you can have an allergic contact dermatitis or an irritant contact dermatitis. Notice how an allergic contact dermatitis will have to have the allergy at the site of the contact with the predisposing antigen. Allergic contact dermatitis, as we have said already, in the Coombs and Gilman classification, in the Gillen-Coombs classification of hypersensitivity, is a type 4 hypersensitivity reaction. It is precipitated by local absorption of an allergen or an irritant through the stratum corneum. So it's going down through the epidermis. With repeated exposure, an itchy eczematous dermatitis develops at the area that was exposed. So you need to have sensitization for the first time. And as with most other allergic conditions, the first time you will not have manifestation. And then the secondary id reaction, it is called an id reaction, is going to develop, which is characterized by generalized acute cutaneous reaction in which pinpoint flesh-colored and red papules develop in areas not exposed to the allergen. Common allergens include, so before we talk about the common allergens, you have the contact area of dermatitis. First time, there is nothing systemic, no more eruptions on the skin. And then if you get enough sensitization, the second time you can have an id reaction that kind of surpasses that original point of contact. What is a common cause of contact dermatitis? For example, nickel from wrist watches. So common allergens include 1, nickel. And what about other common etiologies? We're talking about topical anesthetics. So lignocaine and lidocaine, neomycin, for example. And you say, what? Well, sure, if you're using neomycin creams, then it can also cause atopic dermatitis. You should be able to quickly now derive that many of the medications we use to treat our patients, especially those that are topical, and sometimes they're not topical, they're the ones that can cause or predispose to. Cause or predispose. Which ones will cause? Usually the topical one, because contact dermatitis needs contact. Poison oak and poison ivy, they come from plants and going hiking and going around. In our area in the Middle East, where I work currently, we don't have much of that, but we have other things. Transdermal patches of different drugs and strong soaps or personal care products are also possibilities. Look for clues. So you're going to be, as a physician in training, you're going to be presented with clues, and you're going to be presented with cases, and you're going to need to discuss the cases that you see in real life as well as answer exam questions. So you want to look for clues such as neck rash caused by a necklace, right? To identify the causative agent, you want to then also look for the exact shape and areas of things worn and so on. For patients in whom treatment is refractory, consider patch testing for nickel, fragrance, and rubber. Contact dermatitis, you're not going to do a skin prick, right? You have a skin prick for allergies. You're going to do a patch testing because this is contact. You do not need to pierce the skin. The contact allergen needs to cross the stratum corneum just by being in contact with the skin. So a patch testing, and this is important, differentiate between a patch test and a skin prick test. All right. So what about irritant contact dermatitis? Irritant contact dermatitis is the second thing. So one was allergic contact dermatitis, and in terms of contact dermatitis, irritant would be the second, and this is the third we're discussing under the heading of eczema, where the first was atopic dermatitis. So irritant contact dermatitis is a direct toxin effect, right? Instead of type 4 hypersensitivity, this is a direct toxin effect from exposure to a chemical, and such as cleaning agent or other caustic substance. And it's quite common, and you want to look for occupational exposure and exposure otherwise. For instance, overwashing will often lead to dry, irritated skin and not immune mediated. And here I want to shout out to the doctors that use too much alcohol and advise them to keep some lotion in their lab coat or pockets, because using too much alcohol will dry the skin and can potentially cause you to have irritant contact dermatitis. What about dyshydrotic eczema, right? Dyshydrotic eczema has a very specific name, and that would be pompholyx, right? And it is an extremely itchy eruption. And this extremely itchy eruption is going to be small vesicles that are on the side of the fingers, on the palms, that can occur from wetting and drying, sweating or allergies, wetting and drying, sweating or allergies. It also occurs as a reaction pattern to tinea pedis. And then we have something called xerotic eczema, which is the fourth type of eczema that we're discussing today. And this one is interesting because it usually occurs on the anterior shins of older persons and dry skin. Why is this interesting? Anything in dermatology that causes an effect on the shins is something of a wide differential and can be rather pathognomonic to a few things, at least in the case of clinical vignettes and clinical examination. So you have things like, for example, erythema nodosum, you have things like myxedema, and you have things like diabetes-related skin rashes, which we're going to come to in details later on. So xerotic eczema, they usually occur in the anterior shins of older persons with dry skin. Affected skin will be red, dry, and cracked with multiple fine fissures that resemble cracks on porcelain, right? So the dermatitis is more common in winter and in dry conditions, and this kind of makes it kind of comes as a no-brainer. And so xerosis comes from dry. That is the word, and you need to familiarize yourself with the terminology. It makes dermatology much easier. Remember, xeroderma is a condition of dry skin. Here, I deal with a lot of patients who have xeroderma, and xerotic eczema is not uncommon, and it is because, and although it can come in shins, I'm actually seeing it in my clinical practice on the hands. It's because of extremely dry weather in the desert. Contact dermatitis is, remember, now we're just going to talk about a few points. We talked about 4 types of dermatitis. We talked about atopic dermatitis. We talked about 5 types of dermatitis. We talked about allergic atopic dermatitis. We talked about allergic contact dermatitis. We talked about irritant contact dermatitis, dyshydrotic contact dermatitis, and then we also talked about xerotic eczema. A question I'm going to ask you and come back to later is, what are the causes of dyshydrotic eczema? Okay, fantastic. So to quickly point out a few issues, remember contact dermatitis, you're going to have discrete grouped red vesicles and bully in linear distributions and eruptions that kind of mimic the contact site. And a usual question in the exam will be poison ivy. Remember, atopic dermatitis is a rash that involves antecubital fossae, and there's lichenification and surrounding excoriations. And so you see thickened skin that is red and etchy surrounding the excoriations because of the etching may or may not be superimposed with infection. And if there is an infection, the identification would be rather clear from the clinical picture and from the vignette you will be given. Xerotic dermatitis, you will have the history. You will have steatotic dermatitis. It is characterized by the location on the anterior shin of red, dry, and cracked skin, multiple fissures. So xerotic is steatotic. Okay, keep that in mind. And I advise you to look for pictures as we talk about these conditions. Then I'm going to ask you a question, and I want you to think about what will be the therapy for most of those conditions, right? If you think about them, a lot of it is going to be rather intuitive. For irritant hand dermatitis, you want to treat with washing less and moisturizing more, right? Doctors, alcohol, and wearing cotton gloves inside of rubber gloves when around chemicals or during activities such as dishwashing can help out. Contact dermatitis, atopic dermatitis, and dyshydrotic eczema may benefit from short course of topical corticosteroids, magic drug for symptom relief. For corticosteroids in dermatology, they're actually classified into classes depending on the potency. So saying steroids alone is not something that is acceptable. So you want to know what type of steroid for what type of condition we're talking about. And this is important for eczema. We're talking about 1% topical hydrocortisone for the face and intertriginous areas. And this is a low potency corticosteroid because in the intertriginous area in the face, you do not want to cause any form of skin thinning, such as that comes with cushinite, right? This is what the side effect of corticosteroid on the skin. You don't want skin thinning, and you don't want skin cracking, and you certainly don't want scarring or any disfiguring features in these areas. 0.1 triamcinolone for other body sites. This is a medium potency corticosteroid. And for other body sites, it's fine, we can use it. An interesting note, it's not just about disfiguring. Actually, the intertriginous area and the face have thinner skin. And so it makes far more sense to use a low potency corticosteroid for those areas. So for nighttime, sedating antihistamines to reduce the etching is a great idea. And topical tacrolimus for recalcitrant atopic eczema that is not responding to corticosteroids is something that we can also use, so we have options. What about the potent glucocorticoids? We can use those for the palms and soles because they are the thickest areas of skin. Those are very thick areas of skin, and so we can use the more potent corticosteroids for extremely thick eruptions. And remember, we talked earlier, the thicker the skin, the thicker the lichenification, and so you can use more potent glucocorticoids. Treatment for xerotic eczema consistent of regular emollient use, and mid to low potency topical glucocorticoids may minimize itching and facilitate healing, right? You can use consistent emollients for the xerosis, which is the dryness, and that's fantastic. And if you absolutely have to, you can use a low potency glucocorticoid. Remember that, okay? And usually you want to try prior to glucocorticoid doing something that is less dangerous, right? Emollients alone can be fantastic. And if I don't want to use glucocorticoids, even though they're very widely used, I still want to avoid their side effects. You can try to work on the engagement of the patient, education of the patient, and having them on board with what you're doing in terms of treatment. I want to now take a pause and discuss a treatment principle in dermatology. What are the topical medication vehicles? And when we say vehicle, we're talking about the medication that we can use to actually apply on the patient. And so we have cream, ointment, solution, lotion, gel, foam, and of course we have powders. And what the heck is the difference between each one of those? A cream is mixture of oil and water. An ointment is more oil than water. Solution is rather liquid, so more water. A lotion, texture between solution and cream, somewhat thicker than a solution, but doesn't have as much oil as an ointment. And a gel will be semi-solid, thick preparation. It's firmer than solution and may dry out skin. So gel, you have to be careful of that. So it's free. It can also sensitize the skin, and so can often cause stinging, burning, or irritation, especially if it is the modality of giving a medication to open skin or inflamed skin. Foam, generally used specifically for hair-bearing areas, so shampoos foam out, right? Powder, often used for skin folds that you don't want to be very moist all the time. So they're easy to apply because they dry out moist areas, and they decrease skin-to-skin friction, which sometimes is undesirable depending on the dermatitis in question. So this is a quick kind of recap. Let's try to get an example. For example, a lot of the creams, a lot of the patients will prefer, for example, creams and solutions because they don't like the ointment feeling, which is more oil. And creams may also be irritating to eroded skin and open skin and may penetrate thick scales. Ointment are less irritating. They're the favorite modality actually to prescribe to all patients, and you have to try to explain to them and want them to teach them to love this thick and greasy stuff because it actually protects the skin and provides a nice coating and can help moisturize, especially if you apply some water to the skin prior to giving the ointment, especially if the objective of prescribing the ointment is to to moisturize the skin. Solutions being very liquid means that they can be quite great for hair bearing areas as well. If alcohol based, they actually may dry the skin, so you have to be very careful, right? Again, doctors, alcohol solutions, zero derma. And certain preservatives lead to irritation, but generally solutions are well tolerated, and so you have to understand those things. So these are just a quick example of what we're talking about here. Okay. Glucocorticoids, remember how we said there are low potency, medium potency, and then there's high potency glucocorticoids? So actually, they're classified into 7 classes, and they are the classes in strength of topical glucocorticoids. Many brand names exist, and they're classified from 1, 2, 3 to 7 in Roman numerals. And that is depending on their potency. So topical glucocorticoids are important anti-inflammatory medications. They can be applied directly to the affected area, fantastic, and offer a powerful treatment with fewer side effects than systemic glucocorticoids. They're grouped into classes of 7. Remember, classes of 7. The 1 is the ultra potent, and then the 7 is the least potent. 1 ultra potent because number 1, is the best thing out there, first class, and that's why they're called class rather than group, so that people don't get confused, because if they're groups, they might think that 7 is the most potent, but if you say first class, then first class is the strongest, right? But it's not necessarily the best, because they can be pretty horrible. You can actually have Cushing's syndrome from class 1 glucocorticoid, okay? So you have things like clobetasol, propionate, that's a class 1, and if you give it on the skin or intertriginous areas, then you will definitely have some lasting skin sequelae, and you don't want that. Flodrandironolide, I believe is how you pronounce it, is another example. And then if you look at the least potent, hydrocortisone is our favorite friend. And if you look at the medium potency, then you have triamcinolone, which is a very, very common prescription that we give to our patients. Do not select potent glucocorticoids for the face because of the risk of steroid-induced acne and cutaneous atrophy. So these are the 2 things you want to remember as the skin sequelae that we're talking about. Okay, now let's test ourselves. A healthy 40-year-old female nurse has a 1-month history of vesicular eruptions on the dorsum and distal areas of her hands. Okay. What is the condition? You should be able to immediately diagnose acute eczema, and then you want to select a topical glucocorticoid. Notice that the type of eczema here is not specified, but if those are the questions and these are the only tricks you have, then you can answer that way. So now we can fold the chapter on eczema and move on to the next group of conditions. Let's start with psoriasis. What is psoriasis? So the diagnosis, well, you have typical findings of chronic plaque psoriasis, and those would be erythematous, there would be scaling, and there will be induration on the extensor surfaces, scalp, ears, intertriginous folds, and genitalia. And given those different locations, it's actually rather intuitive for you to think that there are different types of psoriasis, because in medical school, they teach you about extensor surfaces only. That is absolutely inaccurate. Psoriasis may come in different areas, and the different areas are different types of psoriasis, and therefore psoriasis is a group of skin conditions. The nails may be pitted, thickened, loose, or yellow, and may be the only manifestation of psoriasis, for example, to make things even more complicated. So let us highlight a point here. Psoriatic arthritis and spondylitis may coexist in 25% of patients. And so when the vignette or the patient comes to you with a spondylosis and a dermatitis, then you can accurately guess that you are talking about psoriasis. Psoriasis is an area where rheumatologists and dermatologists usually fight on the modality of treatment, and both of them are usually right to choose immunomodulation. Okay, so what are the clinical appearances of common psoriasis subtypes? You may have being intrigued now into the subtypes of psoriasis. We have chronic plaque psoriasis, and this is the one that is thick erythematous lesions with silvery scales. Adherent scales can be found on anywhere on the body. And in medical schools, they give us the pictures of extensor surfaces. That is called chronic plaque psoriasis. This is number one. Number two, we have guttate psoriasis and many small drop-like, and that is the meaning of guttate, drop-like papules and plaques on the trunk, often developing after infection. And this infection would be beta hemolytic streptococcus. Beta hemolytic streptococcus. Okay, so beta hemolytic streptococci, remember, are the group A, B, and D streptococci. And the beta hemolytic streptococcus and they did not really identify which type of beta hemolytic streptococci, but Streptococcus pyogenes, for example. So remember, small drop-like scaly papules and plaques, that will be guttate psoriasis. And this is basically someone who has a lot of so many different small drop-like scaly plaques and papules. They're not just papules. And this is key. So you don't want to confuse that with an infectious etiology. You don't want to confuse that with another condition, which you might do as a naive person who is not accustomed to the skin morphology of guttate psoriasis. So you might start thinking of other infectious causes. You don't want to do that. What about the third subtype? This is a subtype that is termed erythrodermic. And the beautiful thing about dermatology is, although the language is a bit challenging, it is fantastic because it's rather descriptive. And you really want to shy away from all the bizarre words and terms that are based on people, although I am of the school that likes to name things after the people who named them out of respect to their hard work. But dermatology has the advantage of giving you names that describe the condition. So erythrodermic psoriasis is the third subtype of psoriasis. You will have generalized erythema and scaling involving most of the body, often occurring after abrupt discontinuation of systemic glucocorticoids. This is a potentially life-threatening condition. So you want to think of a patient who comes with erythema everywhere and scaling everywhere, and it involves most of the body, and there's an abrupt onset and it is associated with abrupt discontinuation of systemic glucocorticoid. So there is an immune mediation. As you start reading about psoriasis, you should automatically note how the immune system is involved in most of the psoriatic conditions. That will be able to spark your interest into the pathophysiology connected to other systemic illnesses, such as the spondylosis that you can see in psoriatic arthritis. What about inverse psoriasis? And this is the one that just simply kind of throws people out. Notice the word inverse. This one is characterized by red, thin plaques, and there are in variable amounts of scale, and they'll be found in the axillae, they'll be found under the breast, they'll be found in the pannus, and they'll be found in the intergluteal cleft and the perineal area. The pannus, of course, people who have very large stomachs, and the stomach is going down, and then there's a crease in the lower part of the stomach where skin-on-skin contact happens. That area is called the pannus, just like the pannus of the ear, right? But that will be the stomach. And then you have nail psoriasis. Nail psoriasis is, and the reason why inverse psoriasis, going back, the reason why inverse psoriasis is interesting is because it's literally coming on flexor surfaces and skin-to-skin contact surfaces. So it is literally the opposite of what you've been classically taught, which is completely not accurate. And more importantly, those areas are likely to be more moist because they are skin-to-skin areas. And so you should not be expecting to see a lot of the silvery scale at all, because they're naturally being moisturized by the body's sweat and sebaceous secretions. And that means that they're not going to have the silvery scales on them. Okay, now moving to the fifth subtype of psoriasis, we're going to be talking about nail psoriasis. And nail psoriasis is going to have indentations, pits, and oil spots often involving multiple nails. So from the clinical vignette, you can rule out nail psoriasis. And remember that we said earlier on in the introduction to psoriasis that it can only manifest as nail eruption. All right. Now take a minute and think about what will be your favorite type of treatment. How do you want to treat psoriasis, considering the skin eruption, the inflammation, and the autoimmune, molecular mimicry, all of those conditions. So if you're thinking like many of the other skin conditions that it could be glucocorticoids, then you are well, you're not wrong. But we select glucocorticoids for psoriasis for limited localized plaques. Okay. You want to rotate therapy with topical vitamin D analogs, which are calcipotriene and calcitol. And then you stop that and start retinoids, you stop that and you start anthraline, you stop that and you give tar preparations, and then you rotate that to try to modulate the skin. So if it is not a localized area and you're using glucocorticoids, you rotate vitamin D analogs, retinoids, anthraline, and tar preparations. I'm just going to highlight that for future reference. Patients with more than 10% body surface area that is affected by psoriasis, those with psoriatic arthritis, recalcitrant palmoplantar psoriasis, pustular psoriasis, or psoriasis in challenging anatomic areas such as the groin and scalp, those ones you can consider for systemic therapy, because if you are not going to rely on adequate application, albeit the application might be involving too much of the skin and might be 3-4 times daily, it might be rather costing to the patient to be compliant. Those patients, we can consider giving them systemic therapy. You can bring them in for sessions of phototherapy. That's one systemic therapy, so it doesn't have to be parenteral or enteral medications. And then you can give the systemic retinoids, methotrexate and cyclosporin, and those are classics, and those two are classic medications in rheumatology as well. So this is an autoimmune disease, more or less. And then what do we do in most of rheumatologics? When we cannot work with disease-modifying agents, we give them biologics. So here, the same principle applies. If methotrexate and cyclosporin are not working, you're going to go ahead and give TNF inhibitors and interleukin inhibitors, right? Patients receiving systemic glucocorticoids or cyclosporin are at risk of acute erythrodermic or pustular flares with sudden cessation of medication. Okay, so erythrodermic psoriasis is a dermatologic emergency because patients are at high risk of infection, electrolyte abnormalities secondary to fluid loss, and fluid loss itself. And that is why we absolutely hate erythrodermic psoriasis. I want you to take a minute now and go ahead and search nail findings in psoriasis and see how those indentations on the nails look like. And when you see a good number of them, it becomes a bit more intuitive for you to understand what nail psoriasis are all about. And then when you have a chance, you want to go ahead and see those silvery scales with thick plaques and polymorphic redness and coalesced plaques in chronic plaque psoriasis. So you can also search chronic plaque psoriasis. The most important thing is not to be tricked. Never select systemic glucocorticoids for psoriasis. Never. If it's a small plaque, you give topical corticosteroids. If you need systemic therapies, it's phototherapy, it's methotrexate, it's cyclosporin, and if not, it's going to be interleukin inhibitor or TNF inhibitors. It is never systemic glucocorticoids, even though you might be quite tempted and it might be quite tricky not to make that decision. All right, let's test ourselves. So you get a 28-year-old woman who has chronic extensive skin rash consisting of multiple small and large plaques with adherent thick silvery scale covering 25% of the body surface area. Quickly, you should be able to diagnose this is psoriasis probably of the chronic plaque subtype. More than 10% of the skin, we're probably going to consider systemic therapy, maybe phototherapy, maybe give her some cyclosporin. All right, remember we talked about lichenification, meaning thickening of skin. Shall we talk about some of the papulosquamous disorders then? All right, papulosquamous disorders first consist of lichen planus. Remember lichenification? So what is lichen planus? Lichen planus is an acute eruption of purple pruritic polygonal papules that are most commonly present in the wrists and ankles. Lichen planus can also present in the mouth, vaginal vault, penis, and the nails, leading to thickening and distortion of the nail plate. That distortion is quite striking as opposed to the normal polygonal purple papule plaque. Lichen planus, purple pruritic polygonal. Someone must really like the letter P. That's how you remember lichen planus. So what is the treatment? You got it. Topical glucocorticoids. Let's move on to another papulosquamous disorder very quickly. Let's check those off so that we go through our dermatology curriculum. Psoriasis rosea, that is Pityraiasis, psoriasis rosea. So first of all, the treatment is topical glucocorticoids and antihistamine. Why? Because this condition can come with pruritus. Okay, again, psoriasis, pruritus. There's also a lot of P's in dermatology. So patients will present with scaly patches and few centimeters wide. Those we will call herald patch. So they herald the onset of the disease, and then followed by multiple 0.5 to 2 centimeter red scaling pruritic patches along the skin, cleavage lines in a Christmas tree distribution on the back, and lasting 1 to 3 months. That's how you know that this is psoriasis rosea. Now take a minute and actually try to look at that psoriasis rosea. Okay, the Christmas tree appearance, you can kind of call it Christmas tree. If you look at the pictures that you can find online, you might not appreciate it very much. To appreciate what it means by a Christmas tree appearance, go and find the patches and see their longitudinal axis and how they all relate to each other. Then you might be able to appreciate it a bit more. And also, while you're looking at that, search psoriasis rosea herald patch to try to see the patch that heralds the disease. It's usually slightly bigger, and sometimes there's central clearing as well on that. Okay, let's go on and talk about the third papulosquamous disorder. This one is an examiner's favorite. It is seborrheic dermatitis. Seborrheic dermatitis, you're not going to be using corticosteroids. You're going to be using selenium sulfide or zinc and zinc perithione shampoos, right? So you're going to find shampoos with selenium sulfide or even selenium lotion, and it's going to be usually applied on the scalp where a lot of the hair is going to be, or you're going to use the same kind of products on the skin if it is not scalp related. And even you can use ketoconazole shampoos. Okay, ketoconazole, that is an antifungal. So what is it? It's an inflammation. It's an inflammatory, scaly, itchy dermatosis that most commonly affects the scalp, but can also affect the eyebrows. It can affect the nasolabial folds. It can affect the chin, the central chest, and of course the perineum. And explosive onset with wide distribution may be a sign of HIV. And the fact that we use ketoconazole may make you wonder if it's actually something that is infectious, right? And for that, it might be related to a fungal infection. I honestly don't know. Okay, seborrheic, let's find that out. Dermatitis. So seborrheic dermatitis in adults is a chronic dermatitis thought to be caused by an inflammatory reaction related to a proliferation of the normal skin inhabitants a fungus called Malassezia furfur, the one that was previously called Pterosporum ovale, but now it's called Malassezia furfur. This is actually an examiner's favorite. I knew that in my head, but for some reason I forgot it. So we're going to add that to the discussion table here. Malassezia furfur, fantastic. Okay, now we have finished the three most important papillosquamous disorders. Now I want to go back and tell you, do not be tricked again. Psoriasis rosea can resemble secondary syphilis, but does not involve the palms and soles. You want to obtain a rapid plasma reagent test in high-risk individuals. Okay, and extensive seborrheic dermatitis may be a clue to underlying human immunodeficiency virus. All right, so if it's palm and soles, you want to rule out syphilis and don't be a hero. So now let's test ourselves. Another 28-year-old patient, this time a man, is evaluated for severe seborrheic dermatitis of acute onset. And you get a number of questions. The first thing you want to do is test for HIV infection. Okay. How does seborrheic dermatitis look like? You're going to find fine, oily scales around the areas that we discussed, whether it's the scalps, the eyebrows, central chest, chin, and so on. Frequently, the exam will give you a picture of this area, and you're going to find these fine seborrheic dermatitis, fine oily scales around the medial eyebrows. All right. Shall we now talk about psoriasis rosea in a bit more details? Psoriasis rosea was our papillosquamous disorder. Psoriasis rosea is the one that looks like a Christmas tree distribution of pink papules, and those can be termed fine collarettes scale, and it's quite characteristic of psoriasis rosea. It's an inflammatory, mildly pruritic eruption, possibly related to herpes virus 6 or 7, and that's really important, which occur in the spring and fall. If you go back to reading virology from infectious diseases, you can understand very quickly that a lot of the infections have seasonal patterns. And the seasonal patterns that are spring and fall are usually related to herpes. Again, psoriasis rosea is going to be heralded by a herald patch. So it's going to be introduced to you by a herald patch. And the patch is basically announcing that there will be psoriasis rosea very soon. So that is a single raised bright red oval plaque that is usually 2 to even 5 centimeters in diameter, with fine scale and followed by then smaller pink papules and plaques with distinctive ring of scale at the periphery. The scaling on top of the patch is certainly more evident on the herald patch because it's bigger for someone who is not an expert. The lesions follow the skin cleavage lines on the trunk and the chest, producing the Christmas tree pattern because our skin is created in a manner that has those continuous cleavage lines. And so they follow those lines. And that makes you wonder about the etiology of it and if it is related to some adhesion junctions or anything like that. Will be interesting for further reading. So what is the therapy? We did say oral antihistamines for the itching and topical glucocorticoids. They usually spontaneously remit within 1 to 3 months. You want to be able to properly diagnose them because you do not want to confuse that with secondary syphilis, which can be infectious if the lesions are moist. So a patient can come with some papules on their hand, and those can be secondary syphilis. And if their hand is moist, then they can actually transmit the spirochete to other people through even handshaking, right? Not common, but possible. And to be able to reassure the patient, give the right diagnosis and the right treatment, it is fantastic to be able to recognize psoriasis rosea. And furthermore, you want to be sure not to miss secondary syphilis, because then the patient can proceed to tertiary syphilis and then can have neurosyphilis and can have lasting effects, which will really be will really be unholy, if you know what I mean. Okay, so do not be tricked that secondary syphilis can mimic psoriasis rosea. Just simply check the rapid plasma reagent, and if in doubt, or if the patient has risk factors, do a panel for sexually transmitted infections. All right, now we can go on and discuss acneiform lesions. This is a huge topic. So because we have surpassed our half hour by a good 20 minutes, we're going to do that in another podcast. Thank you very much for watching, and stay tuned for the next session on acneiform lesions.